Good morning, everyone. It gives me a great pleasure to introduce our speaker for today. Dr. Stone has earned his bachelor's degree from St. Olaf College in Minnesota before earning a PhD in history from the University of Washington. After deciding to make a significant career change, he completed medical school at the University of Minnesota Twin Cities, where he has been a combined APCP pathology resident for the last 4 years. This is his last year in our program. And next year, he will be pursuing a hematopathology fellowship at the Stanford University. And today, he's going to talk to us about the attempts to evaluate molecular testing patterns for suspected myeloproliferative neoplasms. Dr. Stone presented selected results from this project at the recent conference of Association for Molecular Pathology and was also nominated for an Investigator Award. So with no further ado, Andrew, the floor is yours.
Thank you, Dr. Moroz. As Dr. Moroz mentioned, today we'll be looking at a research project that we put together about molecular testing patterns for suspected myeloproliferative neoplasms. This project also has a quality improvement component, which we'll talk about a little bit later in the presentation. So I have nothing to disclose for today's presentation. So our objectives for today are to briefly review the major BCR-ABL1 negative myeloproliferative neoplasms and the role of molecular testing for specific gene mutations, namely JAK2, MPL, and CALR in their diagnosis. Then we'll look at the data that we gathered from our next generation sequencing results from the molecular lab here to try to identify some patterns in test utilization and the frequency of detection of pathogenic variants, including what kind of pre-test or clinical factors might influence this likelihood of detecting pathogenic variants. We'll look at where this testing could possibly be more efficiently utilized by reducing tests with low pretest probability. So this is the quality improvement component of this project. And then, I'll wrap up with presenting some of the challenges that we actually ended up uncovering or facing in trying to implement this quality improvement component. So for the non-hematopathologists in the audience, I thought it was important to just briefly review what we mean by what myeloproliferative neoplasms we'll be talking about today, and why molecular testing is so important for them. So this is our usual schema showing hematopoietic cell development with a myeloid branch and a lymphoid branch. So we'll be talking about the myeloid branch, and generally, when we're talking about myeloproliferative neoplasms, we're phenotypically defining them by what is the predominantly increased cell type. So acute myeloid leukemia is not a myeloproliferative neoplasm. This is an acute disease where there's a predominance of immature myeloblastic cells. In contrast to that kind of acute rapid growth presentation, most of the myeloproliferative neoplasms that we're going to be talking about are chronic diseases that have kind of slow growth and slow increase of certain cell types. So when the increased cell type is predominantly granulocytes, by which we mean neutrophils, eosinophils, basophils especially, then that's designated chronic myeloid leukemia phenotypically. When the predominantly increased cell type is red blood cells, erythrocytes, we call that polycythemia vera. And when the predominantly increased cell type is megakaryocytes, leading to predominantly an increase in platelets, that's what's designated as essential thrombocythemia. There's a third myeloproliferative neoplasm that's important to recognize here, and that is a proliferation of megakaryocytes, but the megakaryocytes are atypical, and the predominant phenotypic expression is basically an increase in marrow fibrosis and various consequences from that. And so that's what's designated as primary myelofibrosis. And some time ago, back in 1960, it was discovered that chronic myeloid leukemia, essentially all cases of chronic myeloid leukemia, have the same underlying genetic alteration, which was the Philadelphia chromosome, a translocation between chromosomes 9 and 22 that creates this BCR-ABL1 fusion gene. And since that time, it's been discovered that the other myeloproliferative neoplasms that we're going to be talking about, by which I mean polycythemia vera, essential thrombocythemia, and primary myelofibrosis, also all share a genetic basis, not with chronic myeloid leukemia, but with each other. So in 2005, the canonical JAK2 V617F mutation was discovered. And basically, this is a mutation in a protein involved in cell signaling that inhibits an autoregulatory mechanism. So because it doesn't allow an autoregulatory inhibition, it leads to this receptor or this cell signaling pathway being constantly active. And as you can see here in this graphic, this cell signaling is involved in the receptor for erythropoietin, so erythropoiesis, the receptor MPL, which is actually the thrombopoietin receptor, so the receptor for thrombopoiesis, and the receptor for GCSF, which helps stimulate granulocyte production. So in all these cases, you can see an increase in JAK-STAT signaling and an increase in myelopoiesis. In 2006, a mutation in the MPL gene itself, the thrombopoietin receptor, was discovered that was associated with these myeloproliferative neoplasms, and again, leading to a downstream increase in signaling. And then finally, in 2013, a third mutation was discovered in CALR, which is a little unusual because CALR itself is a protein involved in the endoplasmic reticulum. So it wasn't exactly clear at first why this would lead to increased myelopoiesis. But it's actually been discovered that these mutations, which tend to be frame shift mutations, either a large base pair deletion or a base pair insertion, result in an atypical C terminal. And then this atypical C terminal can actually bind to the MPL protein, to the thrombopoietin receptor, and again, lead to constitutive activation and downstream signaling. So this graphic shows the prevalence of each of these mutations in the three major non-CML myeloproliferative neoplasms that we're going to be looking at today. So polycythemia vera is almost always characterized by some variation of a JAK2 mutation. In the vast majority of cases, it's V617F. In some cases, it's an exon 12 mutation. Essential thrombocythemia and primary myelofibrosis have more of a mix, but they're also, the majority of cases have the canonical JAK2 V617F mutation, with the rest having a mix of CALR, MPL, or the so-called triple negative cases. Although even this term triple negative is a little bit of a misnomer because some portion of these cases have a mutation in either MPL or JAK2 that is not the canonical V617F or exon 12, but is still in those genes. Or they have a driver mutation that's been identified in other myeloid cancers, for example. And that's another important point, which is that, while these are the major driver mutations and the ones that, as we'll see, we test for most frequently, 50 to 55% of cases of PV and ET actually have additional mutations in other genes. And primary myelofibrosis in particular is known for having the highest of the mutation burdens among these myeloproliferative neoplasms, which may explain in some ways why it has the worst prognosis. And this is an area of very active research, both in trying to identify various other mutations that might confer a worse or better prognosis for these myeloproliferative neoplasms, and also just trying to understand this question of, if all three of these myeloproliferative neoplasms tend to share the same mutations, why does one emerge with a phenotype predominantly of polycythemia vera, and why does another emerge with a phenotype of primary myelofibrosis, for example? So this is a very active area of research that we don't really have time to discuss very much. The elephant in the room, we are heading into the era where we're going to possibly be dealing with two different classification systems. Fortunately, in the upcoming WHO 5th edition and in the ICC classification of myeloid neoplasms, the classification and the diagnostic criteria are very similar and have not really changed a huge amount since the revised fourth edition. So for polycythemia vera, our major diagnostic criteria include an elevated hemoglobin, a bone marrow biopsy that shows hypercellularity and growth in all three lineages, or what we call pan-myellosis, and then a presence of a JAK2 mutation. And the ICC criteria are essentially identical. So this is an example of a bone marrow biopsy showing pan-myellosis. There's growth in erythrocytes, there's growth in granulocytes, there's hypercellularity, and the megakaryocytes are increased and are showing basically a normal spectrum of morphologies. For essential thrombocythemia, the major diagnostic criteria are an elevated platelet count, a bone marrow biopsy showing mainly megakaryocyte proliferation, and especially the distinction is made that the megakaryocytes should generally be mature and hyperlobated. And we'll see why that's important when we look at primary myelofibrosis. And if you happen to be at the CP talk that Dina gave, she did a really nice job of highlighting these differences and this diagnostic dilemma. And then you need to show the presence of one of these MPN-related mutations. The ICC basically has the same criteria. So this is an example of what the usual megakaryocytes should look like in essential thrombocythemia. They're hyperlobated. The nuclei have many, many lobes, and otherwise they look mature. For primary myelofibrosis, it's divided into a pre-fibrotic phase and an overtly fibrotic phase. But the diagnostic criteria are essentially the same for both, except for just the degree of marrow fibrosis that is seen in the bone marrow biopsy. So one of the features that's emphasized for diagnosing primary myelofibrosis, whether it's pre-fibrotic or fibrotic, is the atypia of the megakaryocytes. And then also, as we can see here, the presence of one of these MPN-related mutations. So in pre-fibrotic or early primary myelofibrosis, the megakaryocytes are atypical, and they tend to have these hypolobated nuclei, sometimes described as cloud-like, and they tend to cluster into atypical tight clusters in a way that the megakaryocytes in essential thrombocythemia often do not. So for overtly fibrotic primary myelofibrosis, the major diagnostic criteria are essentially the same, except for you see a greater degree of collagen and reticulin fibrosis within the bone marrow biopsy. So this is an example of that fibrosis within the bone marrow biopsy, which gives the cells a streaming look on H&E, and then you can see on a trichrome stain for collagen, you can see the collagen fibers in blue here. And you can also see the atypical megakaryocytes. In this case, they particularly have hyperchromatic nuclei, which is another feature you may see in primary myelofibrosis. So the key points of this review are basically that, the diagnostic criteria have not significantly changed in the upcoming systems, which is good for us. All systems include the presence of a JAK2 CALR or MPL mutation, or if you don't have these, you have to have some other marker of clonality. But generally, as we saw in our breakdown of how frequently we see various mutations, JAK2 CALR and MPL make up the vast majority of cases. And there can be some histopathologic and clinical overlap between polycythemia vera, essential thrombocythemia, and primary myelofibrosis, particularly this diagnostic dilemma between ET and pre-fibrotic PMF. So let's get into what we actually did with this project. So first, we'll talk a little bit about the patterns of utilization that we uncovered when we started looking at this data. So this research question emerged from basically anecdotal observations during molecular rotations that NGS testing for MPNs is sometimes requested when the pretest probability is pretty low. For example, someone with elevated platelet counts or elevated hemoglobin that clearly has another explanation. They're in the hospital, they have an infection, they are a longtime smoker, or so on. Or in cases where perhaps there's few data points to support the notion of chronic elevation, right? One of the hallmarks of an MPN is that the patient should be showing chronic myeloproliferation. And so they should be showing chronic elevation, but maybe we see testing requested on a patient who's had a single elevated platelet, or a single elevated platelet last week, and then the only other CBC we have is from 5 years ago and was maybe a tiny bit elevated, and we can't really tell, is that really chronic elevation? Or testing being requested in situations where even the clinician has low suspicion that this is a myeloproliferative neoplasm, but it's sent with the justification that, well, this will allow us to rule out a myeloproliferative neoplasm. And this was, a role that was never intended for NGS testing as kind of a screening or a rule out test. Articles from other molecular pathologists and molecular labs have reported similar observations. This was an anecdotal observation at first. So what we wanted to do was really understand, well, how prevalent is this? And, if this is if this is a potential overutilization of testing, can it be improved while still, identifying the patients who do have MPNs? So the recommended role of MPN testing, as I alluded to, is as part of a comprehensive workup that includes a bone marrow biopsy. Some of the reasons that a bone marrow biopsy is recommended, beyond the fact that, as we saw, it's considered to be part of the major diagnostic criteria for making a definitive diagnosis. One is this diagnostic dilemma between essential thrombocythemia and prefibrotic primary myelofibrosis. Clinically, these can look exactly the same. They may both be characterized by simply elevated platelets. The presence of fibrosis has prognostic implications for polycythemia vera, for essential thrombocythemia, for primary myelofibrosis. And also the one situation that the WHO and ICC and NCCN, for that matter, identify as may not require a bone marrow biopsy for definitive diagnosis is if a patient has sustained elevated red cell counts or sustained elevated hemoglobin and a low erythropoietin level. That situation is fairly specific for polycythemia vera. But it's been observed that in practice, a lot of patients don't get bone marrow biopsies, and there's some understandable reasons for this. One study reported that 58% of patients that had been diagnosed with essential thrombocythemia did not get the recommended bone marrow biopsy, and usually these were older patients. And this is understandable, right? This is not. I'm not trying to fault our clinical colleagues here. There's a balance between the recommendations for definitive diagnosis versus the risks, the potential comorbidities that many older patients have, and whether, if is a bone marrow biopsy really needed in order to start effective treatment. And so it's understandable that not everyone gets a bone marrow biopsy. But there is a concern that's been expressed by molecular labs that, as NGS becomes more and more available and easy to order and cheaper, that it has taken on this unintended screening role where sometimes it's actually the first test that people think of ordering just to rule out the myeloproliferative neoplasm. So, with other people observing this, you might think, well, somebody's probably looked at this question before, and indeed they have. There was a study in 2018 at the University of Calgary in collaboration with Copenhagen University by Mahi et al., where, again, they started with this observation that that the availability of high sensitivity JAK2 testing had made testing easier, more convenient to order on peripheral blood specimens, and that they had observed an increase in the number of tests ordered with a corresponding decrease in their hit rate, or how often these tests were actually positive. So what they did was use this large Copenhagen population study to craft a simple CBC-based decision tree algorithm. So this is a prospective study of about 50,000 general population individuals that all had CBC data and JAK2 results. And as you can see here, the incidence of positive JAK2 was very low, is about 0.14%. But what they decided was that if you follow this decision tree, and basically if anybody has an elevated hemoglobin, you should test them. If anybody has a platelet count above 350, you should test them. And if anybody has a white blood cell count of above 7, you should test them. These are fairly conservative cutoffs. What they found was that you would miss 6 of those 68 cases. So only about 0.01% of this entire cohort you would miss. So basically, they were trying to maximize the sensitivity of this algorithm. When they applied it to their own data from their molecular lab, they found that they would have missed 37 historical cases of positive JAK2 mutations, or 1.2%. So you can see here what they calculated for the sensitivity, which was very high, and the specificity was very low. And we can understand why this is, right? Their algorithm was pretty conservative. It basically emphasized testing 2,500 of their historical patients versus about 430 patients that it recommended not testing. And what they noted was that this would have eliminated 14% of their tests, basically at the cost of missing about 1.2% of positive patients. The hit rate did not statistically significantly change, although there was a trend in that direction. And so after reading this was a very interesting article. But my first reaction was, well, surely we can do better, right? I mean, this is a fairly conservative algorithm that recommends testing a huge number of patients. Maybe we can build an algorithm that's even better and could eliminate even more than these 14% of tests. So what we did was we started with our own data. So we retrieved all specimen results from Genome Oncology, which is our molecular software, from 2015 to March 2022, which is when this project was first started. We sorted it to include all tests that had JAK2, MPL, or CALR results. And what we saw was that there's really 2 main testing modalities for myeloproliferative neoplasms that include these genes. One is what we have as an option of a myeloproliferative panel, which is basically a test for all 3 of these genes. Or there's a testing that starts with JAK2 testing, and then if that is negative, reflexes to MPL and CALR. And so this appears in Genome Oncology as a custom panel. There's also a small number of isolated JAK2 tests from early. Most of these are from 2015, 2016, and then a few other tests that also included JAK2 and MPL or CALR results. But these, because they included so many other genes, basically I've quantified them here, but they're not included for further analysis. These were the 2 main testing modalities. And this shows, when we just sorted to see how often do these return with pathogenic variants. About 20% of the myeloproliferative panels and about 12% of the custom panels showed pathogenic variants or likely pathogenic variants in JAK2, MPL, or CALR. So this is a breakdown of what specimen types we see for these different testing modalities. Overall, about 85% of our specimens for MPN are peripheral blood, and about 15% are bone marrow. And there's a little bit of difference between the MPN panels and the custom panels. But what was particularly interesting is if you look at the rate of pathogenic variants from these different specimens, overall, about 17% of tests returned with pathogenic variants. This was a little bit lower for peripheral blood specimens, but for bone marrow specimens, it was almost 33% of the tests returned with pathogenic variants. So what about this notion that's been brought up in the literature that we've been receiving, more requests for tests with a subsequent less positives? Well, here you can see From genome oncology, the number of MPN tests requests the number of MPN tests we performed each year. I didn't include 2022 because at the time we didn't have complete data for that year. And you can see that there is generally a trend towards increasing number of tests with a little dip here in 2020, probably due to COVID. And also that over time, the custom panels have been making up a little bit of a larger proportion than the MPN panels. In terms of the percentage of positive tests per year, there's really some fluctuation. It's hard to say, is there really a trend downward? Perhaps from 2018 to 2019 to 2020 to 2021, there's a little bit of a decline in the overall positivity rate. But it's difficult to say. Another question that came up as we were looking at this data was, does the ordering provider matter? So we did break it down by who, and just to understand, who requests MPN testing most often. And as we might expect, most often it's requested by hematology oncology, with a smaller percentage requested by pathologists, about 4%. Other mostly primary care specialists, so internal medicine, surgery, pediatrics. And then this large portion here is basically providers that had less than 10 overall tests ordered, which we had to set something of an arbitrary cutoff just to make the number of providers we needed to try to identify manageable. And what we found was that for pathologists, about 40% of these tests come back positive. For the hematology oncology, it's about 18%, and with a much lower rate for the other providers, the ones that we could identify as internal medicine, surgery, or other providers. So what does this mean? Does this mean that pathologists are just so much better at identifying who needs testing? We might like to think that, but really it's probably more related to the fact that if you look at the division of specimen types by provider specialty, pathologists order the vast majority of tests on bone marrow specimens, which, as we saw, tend to be positive much more often versus peripheral blood specimens. And this is understandable, right? The pathologists are probably more likely to order this testing after they've seen a bone marrow biopsy that has evidence of an MPN, or perhaps as a follow-up to a patient who already has a known MPN, or so on. So now we're going to get a little bit into the weeds. So we had this overall data, but we really wanted to try to understand, what factors. Excuse me? Oh, okay. We really wanted to try to understand what other factors influenced how often these tests are positive, and could we maybe do something similar and build some kind of guidance as to when MPN testing is most appropriate. So what we did was we took these 2,289 tests from genome oncology that we had identified with the associated MRNs, and working within the RStudio program, we limited this to patients with any combination of testing for JAK2, MPL, and CALR. And then we also excluded patients that had additional testing because we wanted to focus specifically on this question of, diagnostic testing to try to either confirm or, quote unquote, rule out a myeloproliferative neoplasm. If patients had multiple tests, which some patients did, we used only the first test in our system. And then we used the electronic health record to retrieve all the patient's CBC results from 90 days before NGS testing to 90 days after NGS testing. Of course, we excluded any patients that had opted out of research. And so we ended up with a cohort of 1,482 patients. So this table shows some of the key characteristics of that cohort. As you can see here, the overall percentage of patients that had pathogenic results was 16.5%. The breakdown between men and women, there were a few more women than men within this cohort, but men were slightly more likely to have pathogenic results. And the division between blood and bone marrow specimens was fairly similar to what we saw with the overall data. And again, somewhat fairly similar results in terms of who was requesting the testing. So, as we analyzed all these clinical factors, two really stood out that I want to highlight here. And the first was the age distribution. And this is understandable. Myeloproliferative neoplasms are known to be more common among elderly populations. But what complicates this a little bit is the fact that JAK2 V617F, which is the most studied variant, is more common as that variant itself is more common as people age. And this is, an area that frequently, confounds us in hematopathology, which is what we call, clonal hematopoiesis of indeterminate potential. When someone is not having identifiable symptoms or not meeting criteria for a specific neoplasm, but has a neoplastic associated variant at a very low frequency. So that's one of the the potential wrinkles in all this analysis, is that this becomes more common as people age as well. And as you can see here, depending on where you set the cutoff or who you test, a significant number of elderly patients may have some kind of detectable JAK2 variant. So what we did is we plotted the density of this age distribution between patients with pathogenic variants and those without. And so if we look closer at this graph, what we see is this interesting difference, which is that for the patients without pathogenic variants, the distribution really follows something of a pretty normal bell curve, whereas the distribution for patients with pathogenic variants is much more skewed towards older patients. Although it should be pointed out that there are patients down here who are quite young and still had pathogenic variants. So this is a complicated table and graph, but I think it reveals something interesting. So I'll walk through it in a little bit of detail. Basically, what we did was, based on that skewed distribution, we did an experiment where we said, okay, what if we just set a hard age cutoff at age 30 and said, don't test anybody under 30, test everyone over 30. How would that perform? And then we did a similar experiment at 40, 45, 50, 55, 60, and so on. And so what this graph shows is the plots of the sensitivity, specificity, positive predictive value, and negative predictive value of those age cutoffs. So if we just set a hard and fast age cutoff at this age, how well would it perform? And what you can see is that, the negative predictive value stays high throughout. But there's this decline in sensitivity, kind of really, maybe it declines over the whole span of these age cutoffs, but around 45 to 55 is really where we start to lose some of our sensitivity. And that's what we see in this table as well, right? So I've calculated here the miss rate versus what percentage of negative tests or, unnecessary negative tests would actually be eliminated simply by setting an age cutoff. And as you can see, up until about age 45, our miss rate goes up to about 10%, but we would be eliminating 25% of tests just by saying don't test anyone over 45. So this is not realistic to say, don't test anyone over 45, but it suggests that, if we are going to assemble some kind of clinical guidelines or algorithm, age is going to be a big part of it, because even by just playing around with age cutoffs, we can eliminate a significant number of tests, but have to balance that against how many positive patients are we actually going to miss. The other factor that emerged as being important in our analysis was the platelet counts. So we looked at all the CBC testing prior to patients receiving NGS and tried to see if there was any kind of significant differences between patients that had pathogenic variants versus patients that ended up not having pathogenic variants. And so I have two graphs here just to illustrate some of the differences. When we did this with hemoglobin, we found absolutely no difference between these two patient populations. And it was similar we tried MCV, we tried absolute neutrophil count, we tried some other variables, white cell counts, and basically there was no statistical significance between these two populations. When it came to platelet counts, however, there was. The patients that ended up having pathogenic variants showed, on average, statistically significantly higher platelet counts than those who ended up not having pathogenic variants. And, so we asked this question, might the timing of testing make somewhat of a difference, right? Perhaps patients that are more likely to have MPNs show a more persistent elevated values. So to try to test this question, we divided the CBC results into 4 timing categories. And again, here we're looking only at the CBC results prior to NGS testing. So 90 to 60 days before testing, 60 to 30 days, 30 to 15, and 15 to 0. And what we found when we plotted these was that the patients with pathogenic variants did have overall more elevated platelet counts across all these time categories. So when we calculated the p-values, they were statistically significantly different across all these timing categories. Whereas for hemoglobin, as with the overall results, which we just saw, there was no statistical significant difference across all the timing categories. So, with that in mind, we conducted a few experiments with basically just, again, like we did with age, setting a few platelet cutoffs and seeing how they would perform. So again, we divided patients into pathogenic, those with pathogenic and those with non-pathogenic results. And we looked at each of the time periods to see, did the patient have at least one platelet count above the cutoff that we had designated in that time period? And then we calculated the sensitivity and specificity for identifying patients with pathogenic variants. So again, not that we would do this in kind of our final algorithm, but as an experiment to say, well, what if we just said, don't test anybody who doesn't have a platelet value above this amount? How well does that perform on its own? And so what we found was if you set the platelet count at the normal upper limit of normal that we use in our lab of 450, basically, your negative predictive value is high, as it has been. Your specificity hovers around about 80%, depending a little bit on the timing of when they have the elevated platelet count. But the sensitivity is down here around 70%. So even with setting our cutoff at the normal or at the usual upper limit of normal, we still miss about 30% of patients that do end up having a pathogenic MPN related variant. And if you set the platelet count even higher to 650, as you might expect, the specificity or the sensitivity declines quite a bit. But you do get a lot of specificity, which again, comparing these suggests that patients who have very elevated platelet counts are, I should be more accurate in my statement here. If you set the platelet count this high, you are going to exclude a lot of patients that don't end up having myeloproliferative neoplasms. But your cost for that is that you miss a lot of patients that actually do. So there is a significant number of patients who don't have elevated platelet counts. And so, this is kind of a summary of what I just said. Higher platelet cutoffs are very good at excluding patients without pathogenic variants, but they do miss a significant portion of patients that end up having positive testing. And so then the question becomes, how do we catch these patients and who are these patients? Well, there's a couple easy answers. One is that, patients with polycythemia vera and primary myelofibrosis especially may not have elevated platelets. And so they might make up a good portion of these patients that we're missing. And just in case you were curious, if we were to do a hemoglobin cutoff, the performance is even worse, right? We saw no statistically significant difference between hemoglobin values among these patients. So this analysis is still ongoing. But really, to sum up what we discovered, there's a skewed distribution of positive tests toward older patients. There's a noticeable increase in proportion of patients with pathogenic variants that happens around age 50 to 55. So patient age would likely be an important component of any useful calculation of pretest probability or clinical algorithm or clinical guideline for recommending testing. Among the CBC parameters, the only one that we found that seemed to statistically significantly be different between our two patient populations was the platelet count. But, this upper limit of normal platelet count that we use in our lab, 450, doesn't really show sufficient sensitivity. It misses up to 30% of patients that do end up having positive MPN testing. And this, after doing this analysis, we can understand maybe a little bit more why in the earlier study that I looked at by Mahi et al., they set their cutoff so low because probably they ran into the same problem of having a low sensitivity. And higher platelet counts are more specific for myeloproliferative neoplasms, but they're even less sensitive. So, any kind of model or algorithm that we could build would need to incorporate these multiple parameters, because we have shown that they do have some influence on predicting who has a pathogenic versus a non-pathogenic variant. But our problem is this sensitivity. How do we limit this miss rate to an acceptable level, especially to a level that would be, acceptable for our clinical colleagues? So, this would seem to be a problem that computer assistance or machine learning would be particularly helpful for, right? We have a large amount of data. We have a lot of complicated data, and we have some fairly simple outcomes, right? Either the patient has a pathogenic variant or they don't. So this is a simple classification problem, just trying to predict. If you want to think of it in machine terms, predicting a 1 or a 0. 1, they're going to have a pathogenic variant. 0, they're going to not have a pathogenic variant. So we did experiment with some machine learning models, which are available as a package within RStudio, which is the program in which we've been doing a lot of this analysis. And the two models that we experimented with initially were a simple regression analysis and then a stochastic gradient boosted decision tree model. And basically what this is it's a type of machine learning where the algorithm tries to create a large number of weak models and make predictions using those weak models. And then by combining all those weak predictions together, it makes a strong model. And we did a pretty standard method, which is we took the cohort that we had identified and divided it into basically 3-to-1 between training and testing. So 3/4 of the cohort was used for training, and then 1/4 of the cohort was used for testing. And as you can see in this graph, the area under the curve that came out of this modeling was pretty good in general. In general, a 0.9, almost a 0.9 area under the curve is considered to be a fairly good model. The problem is that this model was very good at predicting who was not going to have a pathogenic variant, but it was in many ways almost a coin flip in predicting who was actually going to end up having a pathogenic variant. So this is just a table showing the performance of these models. And so as you can see here, for patients who did have a pathogenic variant, When we performed our regression analysis model, it predicted that 37 of these patients who did end up having a pathogenic variant would have a pathogenic variant. So we can think of those as our true positives for this model, right? But it missed 22 patients. It said that these patients would not have a pathogenic variant, but in fact they did. Whereas for the patients who didn't have pathogenic variants, it was quite good at predicting that they would not. So the specificity was very high, but the sensitivity was only around 60%. And actually, interestingly, the machine learning gradient boosted model was actually worse in terms of its sensitivity. And so again, we ran into this problem of there's not enough sensitivity. How could we go to our clinical colleagues and say, we really have this great, this great way of predicting who needs MPN testing, but it's going to miss, 40 or 50% of the patients who actually do end up having positive tests. That would not be convincing to anyone. So, why did we have these, somewhat disappointing results? Well, recall looking back at our platelets and our age graphs, that there is, although the patients with pathogenic variants tend to skew older, there is a decent number that are quite young. About 3.2% of our patients with pathogenic variants were younger than 30, and 10% were younger than 45. So we hypothesized that the model particularly has a hard time identifying these patients, especially since, when we looked at kind of what factors was the model using, age was one of the biggest predictors that it was using. And similarly, there's a statistically significant difference between platelet counts among these patients, but there's a group of patients with pathogenic variants that always have low platelet counts or are, cytopenic. And again, we suspect that the model really has difficulty identifying these patients. So, who are these patients? That's kind of the question. They might be cases of primary myelofibrosis. It's known that thrombocytopenia is present in about 20% of patients with primary myelofibrosis at the time of diagnosis. They may be patients with myeloproliferative neoplasms that were diagnosed elsewhere and have now been referred here to the University of Minnesota, right? We are a referral center for bone marrow biopsies or for specialized hem-onc care. And so this may be the case for some of these patients. And then also, some of these may be cases of CHIP or clonal hematopoiesis of indeterminate significance, right? They have a detectable pathogenic variant at a low level, and maybe they don't have any kind of real, phenotypic or clinical manifestations of this. This also kind of illustrates some of the limitations of our data. So we have a large amount of testing data. We have a large amount of CBC data, thousands upon thousands of CBC results, but there's still some important gaps. So when we looked at the patients, some patients have a lot of CBC results. Some patients, were in the hospital and got 50 or 60 different CBC results within our time period. Others have very few. Some may have only one. And, because of the limitations of how much data we could look at, we chose to set our data acquisition to 90 days previous to and then after NGS testing. But, this doesn't take into account, a patient who's had, say, chronically elevated platelet counts over the span of 5 or 6 years, right? We're only extending out to 90 days. And then another question is, how do we handle missing data points? So for these patients that have only one CBC result within this time period, how do we compare them versus a patient who, perhaps has 20 CBC results spanning the whole 90 to 0 day time period? And so this, really illustrates an important point, which is that, myeloproliferative neoplasms they're simple, quote unquote, in terms of their molecular results, right? We're basically looking at only 3 genes with a small number of identified pathogenic variants, but phenotypically and in their clinical presentation, they're very complex, which makes making this kind of pre-test prediction much more difficult. So with that in mind, this is an ongoing project. We've taken some of these next steps. One of them is a manual review of bone marrow biopsy results, clinical and pathologic diagnosis, and hematologic history of all 245 patients with pathogenic testing results. Again, trying to understand better why, who are these patients that were quote unquote missing. We're going to try to repeat this analysis by the MPN diagnosis and specimen type. And incidentally, after listening to to last week's Grand Round speaker about natural language searching, there's a big part of me that says, man, I wish I would have known about that before I spent all this time doing a manual review. But yeah, this manual review is basically necessary because there is no great way of retrieving an accurate diagnosis when we do these kind of automated searches. The diagnoses are all over the place, which I can talk about a little bit more if people are interested. One of the next steps might be to exclude patients that have a previously known diagnosis, right? Because we're most interested in this question of testing being sent to either diagnose or quote unquote rule out a myeloproliferative neoplasm. So we're interested in diagnostic testing, not really follow-up testing. And then hopefully from there, we can make another attempt to kind of build and test some kind of clinical prediction model, maybe a scoring based one, maybe something that you get a certain number of points for your age, you get a certain number of points for your CBC results. And if you're over a certain score, then we recommend going ahead with testing or something like that. And I want to leave you with one last thought, which is, why bother? We did quite a bit of work. It didn't quite work out how we hoped at the beginning when we started this project. So why keep going? Why bother with this project? Well, beyond the fact that, reducing our amount of low yield testing is more efficient and more effective patient care, right? There's also a financial component to this. The current costs billed for MPN panel testing by the University of Minnesota range about $1,500. The current cost to our lab to run and report these tests is about $260 to $270. So let's say we could eliminate 20% of tests. Well, this would represent a savings of almost $120,000 to patients and insurance per year, and it would be a savings of about $20,000 by our molecular lab. So, in the grand scheme of healthcare costs, this is not, the largest number that we've ever seen, but it's not insignificant. And also, the savings in terms of tech time investment, the time that we need to be using equipment to run these tests is likely going to become even more important as everything that we've seen and talked about recently in CP conferences and grand rounds suggests that molecular testing is going to be more and more a part of pathology and of hem-onc care going forward. It's only going to get more prevalent. So the savings in terms of how many tests do we need to run and what's the yield of those tests is going to be even more important as we go forward. So I want to make a few acknowledgments. Special thanks especially to Ryan Martinez, Dr. Ryan Martinez, our molecular fellow, for a huge amount of help with the informatics and analysis side of this project. To Dr. Moroz for encouraging and supervising this project, to Matt Schumacher in the molecular lab for helping provide the initial data, to Vidya in the CISS for helping with the clinical data retrieval, to all the hematopathology and molecular department faculty and staff, and to the whole department for the last 4 years. And then finally to my family for their ongoing support over the last 4 years. So here are my references, and I'll be happy to have a few minutes for questions.
Hey, Andrew, thank you. Oh, Andy, you've got your hand up. I'll let you go first.
Go ahead, but I have to run in a few minutes, so hopefully
Okay.
yours isn't too long.
I have a comment and more of a question. So my comment is, I know you did all that work looking at the chart for the positive cases, but you may also want to consider looking at the negative cases just to make sure that they are not post-transplant MPN patients, because that might also possibly skew your data as well, depending on how close to transplant and everything they are. And then my other question is, you talked about a scoring model, but have you also considered a sequential model? So for example, you showed that a platelet count of 650 or greater was pretty good. Could you then exclude those and analyze the ones that are less than 650 and see if there are other parameters that creep up that then become important, and kind of do more of a sequential, like if you're greater than 650, go ahead and test. If you're less than 650 or 450 or whatever cutoff you decide, then look at these other features.
Yeah, no, that's an interesting idea, and yeah, I think one that is definitely worth exploring. That may be, that may be where we end up going with this once we start. So now that we have, all the data kind of in a usable format within, within the computer where we can kind of write scripts and play around with it, it might be a lot easier to try some things like that. But I like that suggestion.
Cool. Me? Andrew, great talk. And you and Ryan have done some really cool work with this data set. A couple of things, just so you're aware in the background, and I know Ryan knows this. So part of why I put my comment on the chat was I've actually spent numerous hours with Vidya working on this data set. When it first came out, about 1/3 to 1/4 of it was corrupt and inaccurate. We spent a tremendous amount of time troubleshooting why. So the background, and so everyone understands what's going on. So Vidya in the CTSI, she gets routine outputs from me of all of our detected variants across all of our assays. And the alignment of those tests and those test results with other information within the clinical data repository in IHI gets messy fast. And so I know Chris gave a great grand rounds last week, and I'm excited to learn more about those things. But again, my direct experience with this project has been that a lot of that is gloss and lacquer and a facade. And all of the hard work that you've put in to double check that is invaluable, because it's far more accurate to have a brain like you or another resident or anybody looking into the chart and confirming all that information. So do not in any way think that your hard work has been for naught. It has made this a much more robust and much more powerful data set. So that was kind of my commentary, and just so you know the background on it. My question actually is too, though, as you guys are approaching this, I want to flip it. And this is in part because actually we had some discussions on a completely unrelated but similar concept in the Twin Cities Breast Cancer Forum last night, where one of the pathologists from Alina was actually talking about the differences in diagnostic criteria between ADH, atypical ductal hyperplasia, and DCIS and management. And we went through this idea of, does it matter if the patient is 40 or does it matter if it's 80, kind of like you guys were using age in your model. My question is in the biology of these cases, what's the current state of knowledge of actually identifying other biomarkers? So again, my commentary is that $118,000 in savings for insurance is also $118,000 in lost revenue for Fairview. Yeah. But nonetheless, I know, like, layering on more testing rather than trying to come up with models of routine care that might decrease costs. But what is the flip side of this? Like, how can we better understand if you find a JAK2 mutation in essentially a screening patient? How do we what's the state of the art for how can we better understand that patient beyond what we routinely do, which is to do bone marrow biopsies?
Yeah. I'm not aware at this point of any of additional testing that is known to or that is routinely performed that's known to kind of, that's
sure. And I'm
identify.
asking, this is a pure research question. You guys are in research mode, right? And the flip side
I mean, they have found that for patients, and I off the top of my head, the variants that I can think of are like ASXL1, SRSF2, I think. So in patients like, for example, with primary myelofibrosis or an MPN related gene, and they think that it might be a case of primary myelofibrosis, those have been shown to be associated with faster progression to either kind of end stage fibrosis or transformation to a blast phase. So there are other variants that are associated with a higher risk, but clinically, and maybe someone else knows this better than I do. At this point, from what I understand, the clinical risk is basically assessed based on patient age and then their count. So if you're above 60 and you have an elevated platelet count or an elevated hemoglobin, they say, your thrombotic risk is increased. You should be on hydroxyurea to lower those counts. And that's about as much as I know in terms of, what we know about, prognosis going forward. And as far as I know, there's not any testing that we routinely do to try to differentiate high risk versus low risk patients. It's more of a research area right now.
Yeah, Andy, this is Pavel. I think it's a good question, but can you hear me? Actually, I'm on the phone side, so I want to make sure that everyone.
Yeah, we can hear you. And then Bartek's got his hand up.
I'm sorry. So you can argue that there is no you can have an ET with JAK2 for many years, and just having a JAK2 mutation that does not predispose you to suddenly build up on acquired additional mutation, or like having a steep progression. You have patients that can go on 10-15 years with an ET diagnosis. We test them for JAK2, and that's all. They just positive. But the other side of this is that if you look at the new WHO, they keep sort of decreasing the number of VAF required to be significant for the diagnosis. And right now in the new, I think it's ICC definitely, and maybe WHO as well, they require 1% VAF that is sufficient to call as a criterion for a diagnosis. So if that's the trend, and they don't actually, the ICC in their paper, they don't really give any reference where that need for lowering the VAF comes from. So that means in my mind that we're going to see more and more those screening tests and more negative testing, which overall from the whole healthcare system is probably not the right direction. So we just, it was just a kind of study to see what happened. Maybe can we improve that, not in the sense to decrease the number of tests, but improve our positive rates of the tests that we're achieving. And I worry that if we're going to keep lowering the requirements for VAF, we're just going to end up with even higher numbers of over-tested patients.
Go ahead, Bartek.
Oh, sorry, I wasn't sure. So, great talk. I agree. Thank you, Andrew. And I have a more general question, which I asked similar question probably 6 or 7 years ago on a similar presentation, which is, in the current system we operate in, what is the incentive to cancel a test? We see that situation a lot, especially when we triage, because in flow cytometry we receive requests for testing and we triage them to what test should be done. And practically, it's actually, unfortunately, easier to just do the testing than to cancel it, practically, given how many phone calls it takes, how hard it is to reach the provider, and so on. And there is, on the other hand, from the point of view of the system we operate in, it's actually a loss. So I want to bring this issue up because it's actually, I'm sensing that this is the purpose of this talk. How do we incentivize reducing unnecessary testing? Thank you.
Yeah, no, I think that's a really important question. you would hope, and again, this, and I think that this really gets at the problem of, that we run into of what is an acceptable sensitivity, or what is an acceptable miss rate, right? Because yeah, you're absolutely right that if we go to our clinical colleagues and we say, we've helped create, an algorithm that we'd like you to use to decide whether you should order this test or not. But it's going to miss, let's say, 10% of patients that actually have this. Some might be convinced that, okay, 10% is an acceptable trade-off, but I think a lot of people would probably say 10% sounds kind of high. I don't know that I want to, I think I'd rather send the testing and be certain, right? I'd rather quote unquote rule out the MPN. So yeah, I think that's an excellent point that is a much larger question about, how are we going to make something that's convincing that can be adopted? I think it has, there have been examples, again, not related to molecular testing, but, when we can show that testing, has a very low pretest probability, maybe we can change behavior. This example is not, directly comparable, but I'm thinking of things like the Wells criteria for ruling out PE, right? That, if you can show that the pretest probability is very low, then you don't need a chest CT. And maybe if we can achieve something like that, maybe we can make a convincing argument.
Okay, we're going to close for the day. Thank you, Andrew. You did a wonderful job. We will talk to y'all next week. Thanks.
Thank you, everyone.